Good evening, everyone. Assalamu alaikum wa rahmatullah. And thanks for joining us tonight in the session. My name is Hamdi Snoussi. I'm the Senior Medical Manager with GlaxoSmithKline for the Gulf countries. It's my pleasure to be with you today for this important event about antimicrobial resistance, as this week we are celebrating the World Antimicrobial Awareness Week. As you all know, that the antimicrobial resistance is one of the most challenging threats that humanity is facing. So we need to act all together to fight this threat. It's our pleasure again to collaborate with UAE AMR committee, who are doing amazing efforts to combat the AMR in UAE. And just a disclaimer that as GSK, we have offered the support for this meeting, but we don't have any influence on the content developed by the AMR committee member. So without any further ado, I would like to welcome Dr. Najiba Abdul Razak, Head of Medical Department at Kuwait Hospital, Head of Infection Prevention and Control Central Committee, Dubai, UAE, and co-chair of the AMR committee in UAE. Dr. Najiba, please join us.
Assalamu alaikum. Thank you everybody for being here physically, and thank you for the people joining us online. Before I start, congratulations to Saudi Arabia for winning today. I think it's a great achievement. Welcome to today's symposium. As mentioned, this is a pure scientific program. However, it's part of GSK's celebration of the World Antimicrobial Awareness Week. We all know that researchers estimated that antimicrobial resistance in bacteria, caused by bacteria, estimated to 1.27 million deaths in 2019, and we believe it's higher now. And if we don't do anything by 2050, the death to antimicrobial resistance will be 10 million deaths, surpassing other causes of mortality like cancer, diabetes, and ischemic heart disease. World Antimicrobial Awareness Week is a global campaign that is celebrated annually to improve the awareness and understanding of antimicrobial resistance and encourage best practices among the public and the human health, the animal health, and the environment. A One Health approach is what we all look for to improve AMR. We also encourage stakeholders and policymakers during this time who all play a critical role in reducing further emergence and spread of AMR. This year, the theme of WOW is preventing antimicrobial resistance together, where all sectors encouraged to the prudent use of antimicrobials and to strengthen preventive measures addressing AMR. We work together collaboratively through a One Health approach. So we hope today, through this symposium, we spread knowledge to better preserve the efficacy of these critical medicines. As we all know, fighting AMR is a truly global endeavor and must be addressed by everyone, everywhere. So without any further delay, I would like to introduce our speakers for today's session. Dr. Jens Thompson, he is the Section Head of Environmental Health in Department of Health, Abu Dhabi. He is the Chair of the National Antimicrobial Surveillance Subcommittee, and he is the President of Emirates Society for Clinical Microbiology. Today, he will talk to us. I would also like to introduce our all speakers together, perhaps, so you all get excited with our program. Our second speaker is Dr. Nihad Al-Shirawi, who is a consultant intensive care at Fujairah Hospital. She's the chair of the National Antimicrobial Stewardship Program in UAE. And our final speaker, Dr. Ma'ina Zain, she's a consultant infectious disease at the American Hospital UAE, and she is a very active member in the Antimicrobial Stewardship Committee as well. So to start with, Dr. Jens Thompson will start his presentation on UAE AMR surveillance.
Can you mute this one now? Well, good evening all together. It's a pleasure for me to be here. And I would like to talk about the data that we are collecting in the UAE on antimicrobial resistance. So we have a national AMR surveillance system, and the Ministry of Health and Prevention just published the annual report, surveillance report, and the presentation will be largely about this data that we are publishing in this report. Can I have, the next slide. So I have no conflict of interest to disclose. We developed the slides ourselves as the National Committee for AMR Surveillance. So the objectives of this presentation will be to, this one is mute, right? To describe the actual system that we have in place in the UAE to collect and analyze and report on the AMR data, as well as to describe AMR resistance patterns and trends in the UAE. And so as we have in the UAE, as Dr. Nachiba mentioned, we have a higher committee for AMR chaired by Dr. Nachiba and Dr. Hussein Al-Rand. And under that committee, we have three technical subcommittees. One is on AMR surveillance, and this is what the presentation will be largely about. We have a stewardship committee, and Dr. Nehat Shiravi is with us today. And we have the infection prevention and control committee. As a committee for surveillance, we are concerned about data, epidemiology, and describing the burden of disease and the levels and trends of resistance in the UAE. This was one of the last meetings before we had the corona pandemic hitting us in November 2019. So this is not even all members of the committee. So we are meeting every now and then and discussing the data and how we analyze and report on it. So our main functions are to develop protocols on how the hospitals and clinics and centers are collecting and generating and reporting this data. We are analyzing it, we are reporting on it like today in a presentation or also in the actual report. We provide technical assistance to the hospitals, build capacity there so they can utilize their own data better to make their own better informed treatment decisions. We also report the data to the WHO in the global level so that the GLASS system or global AMR surveillance system can utilize the data from all the countries and make a global report. And we report to the higher committee, of course. So this is the actual report, as you can find it on the MOHAB website. So you can download it, you can print it. It's there as a PDF available. And also, as I said, the WHO is also using the data from the UAE to report on a global level, and you can also get access to this from the WHO website. So it's actually easy to download it. You go to the mohab.gov.au website. There is this open data section, Mohab Open Data. You can download our resources. You can type a keyword to search for AMR, and there the report will be. So how is our national AMR surveillance system constituted here? In any kind of national AMR surveillance system, we need, of course, the sites where the patients are seen and treated. These are the hospitals, the clinics, the centers. This is where the data is generated. This is what we call the surveillance sites. And then we have a national coordinating center, which is actually the surveillance committee as an interim function, because we do not have established a full body of a national coordinating center with a budget and with the staffing. This is still a work in process, but the surveillance subcommittee is serving as an interim in this function. We also do not yet have a national reference lab for AMR in the country, so this is also under process. The WHO gives some recommendations for countries on how they should design and develop their national surveillance systems, and most of these components we have in place. Especially, we have a laboratory network, we have a surveillance protocol, we have a defined flow of information, we have a software for data collection and analysis and reporting, which is the HUNET software, which is used on a national level and also at hospital level. Also, we have external program for quality evaluation, but I put it in bracket because it's not a nationally coordinated effort. It's each hospital themselves, each lab themselves, they are participating in external quality assurance. But for example, the national reference lab is still missing from the system. So this is kind of how it looks right now. So we have in all the 7 Emirates, from Abu Dhabi all the way to Fujairah, we have hospitals and clinics and centers and labs reporting this data on a routine basis, either monthly or quarterly or annually. All the concerned health authorities are acting in the middle and forwarding the data to the subcommittee, and this is where it then gets analyzed and reported. So in total, we have 318 surveillance sites, 87 hospitals, 231 clinics, 44 microbiology labs, and they are all part of the system, and all the concerned health authorities are officially part of that system. This again shows like the number of hospitals, clinics, and labs in each emirate, and the heat map shows where they are located. So we can say from the west, from Al Zilla down to Liba, Oasis, all the way to the north and the east, Fujairah, Ras Al Khaimah, we have the surveillance site. So we can say it's largely representative for the country as a whole, with some few limitations, but the data represents the country quite well, I would say. This is just the same information, but now broken down by public versus private facilities. And as you can see, the orange dots are the private sector facilities, and they are concentrated mostly in the large cities like Abu Dhabi, Dubai, and Al Ain. Whereas the blue dots are representing the public healthcare facilities under MOHAB, under DHA, under DOH. And you see they're also very, very important because they are covering the more, let's say, also the rural and more remote areas. So both together give a nice picture or paint a nice picture of the situation in the UAE. We started this effort in 2010 at Abu Dhabi level with Abu Dhabi Seha facilities only. And then you see the first 3 years it was just Abu Dhabi Emirate. And then in 2013, we had already 5 Emirates reporting. And from then on, 2014 on, it was all the 7 Emirates. So we have it established since a couple of years on the national level now. And you see the number of hospitals, public hospitals reached 42, and this is pretty much the whole we have. So we have full coverage. At the private hospitals, it increased to 46 now, and there's still some room to improve. We can even have some more now as well. And then centers, clinics, public, private, is all there. And you see, even from 2019 to 20, the interesting increase is 27%. So the year where COVID came, we had still more facilities reporting. But as you can see, this here now shows the number of isolates reported. And also accordingly, of course, the first 10, 11 years, the number of isolates reported increased, of course, with the number of facilities reporting. But then in 2019-20, you see there was a decrease. So this is unusual because we had 27% more facilities in 2020. As I can just go back, you see 27% more. But the number of isolates decreased actually, right? So this is obviously the effect of Corona, of the public health response to Corona. Altogether, we can say that we have about, should say 198,000 and 205,000. Not sure, there's a little typo. So we have about 200,000 isolates per year reported. So this is a quite good number, which allows us to make good statistical analysis. And you see there is some screening and copy strains and quality control isolates, and we remove these routinely from the analysis. So we look only after the diagnostic isolates, the 53% or 104,000 diagnostic isolates, let's say last year or 2020, which is actually patients. So this is not only isolates, this we can say is patients. Just one look at the labs. As I said, there's 45 or 44 labs now. On the right side, you see there all of them are participating in ECAS, which is external quality assurance. All of them but one are accredited by either CAP or ISO or ACI, and they're mostly in Abu Dhabi and Dubai, but in each of the Emirates we have some labs. So this is the system as it stands, and we come now to the actual AMR levels and trends in the UAE, and maybe we can also shed some light on the potential impact of COVID-19 on bacterial infections. As we just have seen this data here, we would have actually expected in 2020 about 225,000 isolates based on the number of sites reporting. But what we actually observed was only 198,590. So there's a difference of minus 12% or 26,000 isolates missing. And this obviously could be an effect of COVID-19 pandemic. And how we can maybe prove that with more data and evidence. Well, let's look at respiratory tract infections, especially in the community, like outpatients. So on the left side, you see the number of isolates reported 2010 to 2020. for outpatient respiratory tract infections. And as you can see here, the number increased accordingly, of course, in the first 10, 11 years of the surveillance as we had more and more facilities reporting. But then this is the same information, and now you see the year 2020 as well. And this is where you see a huge drop of minus 49% in outpatient respiratory tract isolates reported to the system. And this obviously is due to the response of public health to corona. So we were all wearing the face masks, we were in lockdowns, well, not really lockdowns, but we were at home offices, we were avoiding social gatherings. And of course, people were avoiding treatment in facilities. They were scared they would get COVID. So that all helped, of course, to reduce not only the transmission of COVID-19 viruses, but also other viruses and also other bacteria who are commonly responsible for respiratory tract infections, like, for example, SPN, which is pneumococci, HIN, which is Haemophilus influenzae, and BRA, which is Branhamella catarrhalis. So overall, the pathogens that we are focusing on for the AMR surveillance are accounting for about 3/4 of all the isolates that the labs in the UAE are reporting or are identifying and finding in their daily routine clinical practice. And most of them are E. coli, Staph aureus, followed by Klebsiella pneumoniae, Pseudomonas aeruginosa, Enterococcus candida, and others. So these are like our priority organisms for AMR surveillance. These are like what is important to monitor in terms of level and trends of resistance. And the World Health Organization here on the left side, you see they came up with a recommendation published in Lancet Infectious Diseases, where they looked at certain drug combinations as very important or critically important or highly important for the development and research of new drugs that will be needed to treat these infections. But also we use this list as kind of a priority list for AMR surveillance. So we need to know kind of what are our resistance levels in these regards, like Acinetobacter baumannii, Pseudomonas enterobacteriaceae, resistant to carbapenem. So carbapenem resistance is a top urgent priority, and these are our last resort broad spectrum antibiotics, and we need to at least know where we stand and what's the resistance level, and of course work on reducing these. So we do know, for example, that we have 21.9% resistance of Acinetobacter baumannii to carbapenems, 14.5 Pseudomonas to carbapenems, 4.0 Enterobacterialis on average. It of course varies by the species, and we have an ESBL level of about 26-25%. So this is what we know. Also, the second priority, we know that we have about 9% of vancomycin-resistant Enterococcus faecium in the UAE. 35.1% are MRSA of the Staphylococcus aureus, and especially for Helicobacter and Campylobacter, we have actually not really data for some very well-known reasons. And then there is some other data on Salmonella, Neisseria, and we have also, of course, the pneumococci here with very good low resistance levels for penicillin and Shigella Haemophilus. We have the information, so we know where we stand. We have a baseline, we kind of know where we are, and every year we're updating this data, so it's well known. So this is like a snapshot of 1 year, like 2020. What's the situation in that year? But we want to know, like, what's the long-term trend? How is the resistance going up and down over the years? And we are doing this since 2010, so we have 12 years of data. And yes, of course, we can do the long-term trends. And so you see here for the gram-negative bacteria, what are the good news, bad news? And just look at the color, just look at green or red. Do you see more green? Do you see more red? And where do you see it? Obviously, the most red we see in the second column, which is Klebsiella pneumoniae. And you can see with all these red arrows going up, that means that all the resistance to these all classes are increasing in the long-term trend. So over 10, 11, 12 years, we see increasing resistance, especially for the third and fourth generation cephalosporins, but also for the carbapenems like Meropenem, and also for Amoxiclav, Augmentin, and others, and multi-drug resistance itself as well. But we also have some good news, especially if you look at the very right Acinetobacter species, we see that resistance is going down. So it's not all bad news, there's also good news. And resistance is also coming down. And we don't really quite understand why it's coming down, but we observe the trend. That's the fact, that's the evidence, and that's how it is. So for gram-negatives, it's a bit of a diverse picture here. And we can basically say the first three are Enterobacterales. The other two, they are the non-fermenting gram-negative rods. So they are kind of two different classes of gram-negative bacteria. And in the non-fermenters, we have the good situation. And in the Enterobacterales, E. coli, Klebsiella, and Salmonella, we have kind of a not so good situation. With the gram-positives, how it looks there, again, the most red color we see in the first column, which is Staphylococcus aureus. So this is the biggest concern. We see increasing resistance, especially for beta-lactam antibiotics, the MRSA, the oxa resistance, but also all the others like macrolides, vincosomides, the clinda, the genta, the fluoroquinolones, except the glycopeptides, vancomycin, tryptophanin. Fortunately, we don't see resistance there. This is, of course, still very good. But all the others are increasing over time, and also pneumococci are increasing, the enterococci. So across the board, you see a lot of increasing resistance in the gram-positive organisms. And this is a concern, of course. This is not good. This is creating a lot of problems. Just one word on the fungi, Candida albicans here. It's a kind of a diverse picture. For the fluconazole and voriconazole, we see increasing resistance, and I will show the details later. For the echinocandidates, it's like decreasing resistance. So good situation there, but the fluconazole is a concern. For the tuberculosis, we see a low-level multi-drug resistance with 3.2%, but overall, it's increasing from 2 to 3% over a long time. So also on a slow level, but it's increasing as well. So if we look at the report, there's a lot of data in the report, and how we structure the report and how we structure the tables and graphs in that report. So first of all, when we get these isolates, we do what we call deduplication and cleaning of the data, and we remove all the quality control and all the duplicate isolates and screening isolates. So we have like inclusion, exclusion criteria, and we end up with the diagnostic isolates or patient isolates. And then we do some characteristics, and it's all in the report. But the important part is cumulative antibiograms, multi-drug resistance, and AMR priority pathogens. So looking at cumulative antibiograms, this is like how it looks. So it's a very detailed view on here only gram-negative bacteria. All the antibiotics that are clinically relevant and routinely tested are reported here in terms of percent susceptible isolates. So this information can be used to develop standard treatment guidelines and help hospitals developing their own local standard treatment guidelines, or also on the national level. And Dr. Nehat will maybe report on it today, or you're also reporting on the standard treatment guidelines today? Yes, okay. So she will probably mention that as well, how we use the data and utilize the data for informing and developing standard treatment guidelines. Same for the gram-positive bacteria. So for example, we can see Staphylococcus aureus, oxacillin 65, and 65 means percent susceptible. So the difference to 100 is 35. So that means an MRSA level of 35. So we can kind of see where the resistance also is in this regard. So this is about the cumulative antibiograms. When it comes to multi-drug resistance, this is what is the actual concern, right? We are concerned about multi-drug, extensively drug, and pan-drug resistant organisms. So this is a summary for the UAE 2020 on where we see most of the multi-drug resistant organisms. Well, this is with Escherichia coli, 44% of them are multi-drug resistant already. Where we do see the most XDR and PDR, and just to maybe elaborate more on what does XDR, PDR, and MDR means. MDR means it's an organism that is resistant or non-susceptible, to be correct, to at least one antimicrobial agent in at least 3 different classes of antimicrobials. That is an MDR. As the XDR means that everything is non-susceptible except 1 or 2 classes. So the doctor has only 1 or 2 classes left to treat this organism. And pan-drug resistant PDR means everything is resistant. The doctor has no choice, right? Nothing is susceptible. So we see the most XDR and PDR in Acinetobacter, which has traditionally always been a very multi-drug resistant organisms. So in the summary total, you can see that we had about 25,000 MDR organisms reported to the system in the year 2020, or 34.7, which means 1 out of 3 of these priority organisms is MDR. 1 out of 3, 1/3 of all these organisms is a MDR, multi-drug resistant. 4.6% or 3,300 are XDR, like 5% we can roughly say, and 1% are pan-drug resistant. So we had about 479 pan-drug resistant, which seems to be a small number. But if that's a patient with a life-threatening infection, like a bloodstream infection, it's a serious condition, and the doctor has no choice for giving any antibiotic in this case. From the normal range. So this is the same data as a bar chart. So we see again E. coli with the 44% MDR. We see Acinetobacter in the middle with the highest rate of XDR and PDR. And then like for all the organisms, how it is. We can also nicely see Enterococcus faecalis faecium, the difference in MDR. So faecium is known to be much more resistant than the Enterococcus faecalis. In terms of long-term trends, we see for the Enterobacterales again, E. coli, Klebsiella, Salmonella, we see kind of horizontal trends, but except for the Klebsiella, where we see from 20% it increased to 37%, and then it came slightly down to 34%. So it was overall, the long-term trend is increasing, but the short-term trend over the last 4 years is kind of stabilizing and coming slowly down. So this is the good news within the bad news. And for the, we don't see much difference between 2019 and 20. But for the non-fermenting gram-negative rods, the situation, as we said, is more green than red, which means that the rates are overall decreasing. And you see for Acinetobacter, especially from 49 to 23% MDR, that is like 1 out of 2. It was in 2013, and then 1 out of 4 is now only multi-drug resistant, which is like 23%. And even for the Pseudomonas, we see it comes down slowly from 22 to 16%. So that's good news. The multi-drug resistance in these organisms is getting lower and lower over time. That is good. For the gram-positives, we see a different picture. So the situation is diverse. As we said, gram-positives are a problem because they are overall increasing. And you see Staph aureus, the green line, from 26 to 40%. The long-term trend increasing, but however, it kind of plateaued and stabilized a bit in the last 4, 5, 6 years, or even came down, you can say. So still, it's an issue, and it's much higher than many other countries in the world. MDRO rate for Staph aureus 40% is a lot, and just the MRSA rate of 35 is a lot compared to many other countries. Pneumococci, we see it's a bit kind of fluctuating up and down, but overall, it's also increasing. And look at the line at the bottom. This is Enterococcus faecalis, which is usually a very susceptible organism. And it didn't have any multi-drug resistance in the first couple of years. And then you see it jumped to kind of 4, 5, 6% now. So even those very susceptible organisms are slowly, but surely becoming multi-drug resistant now. So we can say it's not much, it's just 6%. But already that is a concern, and you see it continues to go up. So maybe next year we have 7, then 8, then 9, then 10%, and so on, right? So this is a concern from an epidemiological perspective, and being a public health microbiologist, this is a concern. Tuberculosis, it's on a low level. You see between 0 and 5% multi-drug resistance. It's kind of fluctuating a bit because the isolate numbers are not that huge. That's a couple of hundred isolates only per year. But we see from 2.4 to 3.2, and it's a statistically significant trend, also increasing trend. So it's still on a low level, and it's increasing very slowly. But even with this multi-drug resistant TB, we see a slow increase. And this is just levels and trends, and maybe someone thinks, well, okay, this is what the microbiologist has to say, but actually these organisms, they have the potential to kill. They are actually very virulent organisms that have the potential to cause not only life-threatening disease, but actually to cause also death. And we have looked, for example, in a subgroup analysis at gram-negative bloodstream infections, where we see, again, let me go back to the slide, where we see that in, let's say in Abu Dhabi, we have about 2,500 gram-negative bloodstream infections every year, and in this group of hospitals. And out of them, 285 on average are dying from a gram-negative bloodstream infection, like E. coli, Klebsiella, these kind of organisms. And these 285, we were interested in knowing, like, who of them is at higher risk of dying, and who of them is of higher risk, a higher chance of survival. And one factor is, of course, age. So the newborns have a 15.5% of dying from this. 32, 33%, the elderly. So age is obviously a risk factor, and it depends on the age. Gender is not really a risk factor. Male, female, there is no significant difference. But now looking at the resistance level, and on the right side, we see now, if we look at the underlying organism, the organism that causes the gram-negative bloodstream infection, is it a multi-susceptible one? Is it a multi-drug resistant or even extensively or pan-drug resistant organism? And how does this affect the mortality rate? 2 minutes only, okay. So you see that the mortality rate goes up from 14 to 29 to 42 to 70% over time, or over all these susceptibility levels. So the pan-drug resistant organism is much more likely to cause a fatal outcome of this. So yeah, and I will not go into all the details for all these priority pathogens due to the limited time we have, but you can find all of that in the report. The details for each of these organisms, the trends for Staph aureus, for example, where we see the resistance levels going up for all these classes here. Also the left side, we see Oxa, Moxi, Levo, Erythrum, Clindamycin, and on the right side, others. And we can do breakdowns, and you will find that in the report. So we can say by age group, how does, for example, the MRSA rate varies, or by emirate, like Dubai has 33, Abu Dhabi 36, on average is 35. Sarkaima is a bit on the higher side. So we can do these kind of things, or by patient location type and see, okay, outpatient have usually a lower resistance rate, and it's best to inpatient and ICU, resistance rate increases. So these kind of things, you will find it in the report. Also kind of a comparison for the different facilities, like where the hospitals kind of are, or even by patient nationality. And that could perhaps even be used to come up with like screening policies for certain high-risk patient groups. Same we have here for the pneumococci, and I will just go a little bit faster over these because we have kind of the details are in the report. We see the increasing ESBL rate, which is the orange line with the black dots for the Escherichia coli here. So the long-term trends, you see, the changes are kind of slowly happening, but they are happening, and over time we see differences and can see where the levels are going up and down. For the Klebsiella, as we said, carbapenem resistance rate is about 5%, and CRO-CTX, which is the third generation cephalosporin, is about 24, 29%. So this is like the ESBL rate we have in the UAE. These are the trends over time, and let's just continue. For Pseudomonas, for example, we see the highest resistance with imipenem. Meropenem is a little bit better. We have Chaz with 6.9%, Ceftazidime 8.8, Cefepime 6.1. So these levels, we know where we are. And as we said, the resistance levels are generally kind of slowly going down for most of the classes, except maybe for ciprofloxacin, for example, fluoroquinolones. Acinetobacter, you can see from the high bars that this is a more resistant organism. But only the good news with Acinetobacter is that if we look at the long-term trends, then we see across all the classes of antimicrobials, it's going down. Resistance levels are really coming down for all the different classes. And we don't really understand the reasons why, but it's obviously happening. And it's a good news, of course. Yeah, we can do breakdowns by emirates. We can do breakdowns by location type and say what's the situation outpatient versus inpatient versus ICU. And you see, for example, ESBL rates, how they get up. If you go to the ICU or carbapenem-resistant Klebsiella, in ICU it could be up to 10 or 14%. In outpatients, it's only 2%. So of course it varies, and we need to be aware of these differences. Just one word on the Candida and Candida auris at the end. So Candida auris is an emerging multi-drug resistant yeast, and we see about 200 cases now in 2020, and it's about 4.2% of all the Candida, which is still the most, of course, but it's emerging. We see these are the resistance trends which I have shown for Candida albicans, where we see the increasing resistance of fluconazole and voriconazole. But on the other hand, the dark green lines, you see caspofungin and micafungin coming down to about 1%. So this is good news. We have low resistance for these echinocandins. But now coming back to Candida auris, we see it was not known a couple of years before, but then in 2017, 18, 19, you see how this organism is emerging in the UAE. It's still a small fraction of all the Candida, but 4.2%, it's coming more and more now. And we also observe a shift from Candida albicans to Candida non-albicans species over time. Because back in 2010, it was about 80% of all the Candida were albicans and 21 were non-albicans. And this has reversed now. So we see 47% albicans, only 53 non-albicans. And this is mostly true, due to these three Candida species here, Tropicalis, Parapsilosis, and of course, Candida auris, which is just recently emerging. This is tuberculosis, where we have good susceptibility levels above 90%. And I think, yeah, we can kind of skip over these slides. We just wanted to highlight the MDR TB rate is slowly going up. As we said, pyrazinamide is going down. So these are details. There's no data for the second-line TB drugs because they are not routinely tested. But overall, you can find all of these data and results in the published report, which is available online. And if we have to put any kind of summary and conclusion, we can say that overall antimicrobial resistance is increasing in the UAE, not everywhere, but for certain organisms, which are mostly the gram-positive bacteria, especially Staph aureus, but also some enterobacterales like Klebsiella pneumonia are a concern. And on the other hand, there's good news where AMR is stable or decreasing in the UAE, mostly for the gram-negative non-fermenting rods like Acinetobacter and Pseudomonas. And if there's any effect of COVID-19 pandemic on AMR, we can maybe say that we have a reduced incidence of bacterial respiratory tract outpatient infections observed in 2020 versus 2019. But on the resistance levels, it's kind of too early to say if it does have a significant impact on the actual resistance levels. And I think overall, what are the implications and recommendations from this report? I think it shows that we still have some issues and problems that we need to address more, and we need to have more efforts to combat the rising AMR in the UAE, especially more infection control, more screening, more maybe isolation even of high-risk patients of certain multi-drug resistant organisms and patients, and more diagnostic stewardship, also and more antibiotic stewardship. And this is what we are going to hear in the following presentations. And thank you very much for your interest.
Thank you. Thank you very much, Dr. Jens, for such an elaborative presentation about the national AMR in UAE. Please, we'll take the Q&A at the end of the whole session. If you're online, please post them on the chat so we can get to them as well. And the audience will have to stay for a while. So our next speaker is Dr. Nihan Shirawi. She's a consultant intensive care at Fujairah Hospital, the chair of National Antimicrobial Stewardship Subcommittee. She will be talking to us about the national UAE UTI guidelines.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. I would like to thank GSK for giving us this opportunity and collaborating with us to present the national report, AMR report, and our national guidelines. The national guideline of UTI will be discussed in this presentation. This is these are the members of the National ASB Committee. A majority are from Dubai and Abu Dhabi, as expected, but we try to include from all 7 Emirates members. It is established in 2018, and we are doing monthly meetings, and we have a lot of activities such in collaboration with the pharmaceutical companies to increase the awareness of the healthcare workers about ASB. So we started with, our plan was to establish several guidelines. Now that we started with the first guideline, which is on the MOHAB website. It was launched last February 2021. and will be due to review according to the new data next February, inshallah. This guideline, we do not discuss urosepsis, CAUTI, or other aspects such as how to diagnose and so on, or indication for admission. We are just concentrating on the antibiotic management. So I will start with the microbiology of urinary tract infection. It's very important to know which bacteria we are targeting. So what do you think the most common organism causing UTI? Yeah, E. coli. Yeah, it's the most common organism. So we have to differentiate between complicated and uncomplicated UTI. We will discuss the definition later. The most common organisms in uncomplicated UTI is E. coli, Staphylococcus subprophyticus, and Proteus and Klebsiella pneumoniae. While in complicated UTI, again the same, but Klebsiella here comes immediately after E. coli. So this study, I tried to look into different studies in UAE, which looked into the microbiology of UTI. And for example, in this study, which was published in 2018, they tried to look into the risk factors for community-acquired ESBL, which is very important. We know who are the patients who might have or come from the community to the clinic or to the ER, and they might have ESBL. And they looked into the risk factors, for example, is recurrent UTI, and this is explainable because these patients receive multiple courses of antibiotics, so they are at a higher risk of ESBL, patients who have urinary catheters at home, and older patients. So what they found also that the majority of ESBL are resistant to ciprofloxacin, and the resistance is 74%. So ciprofloxacin is no more a good choice to be started empirically, especially in these patients. Also, trimethoprim, sulfamethoxazole, also resistance is high. And this is another also study in UAE, and they looked into the resistance of community-associated UTI. This was in Sharjah. And as you see, E. coli accounts for almost half of the cases of UTI, and followed by Klebsiella. So what do you think after, I will test whether you were concentrating with Dr. Jens or not. So the sensitivity of E. coli to Cipro is around 80, 70, 60, 50, 80, 60. Okay, it's around 60%. So it's high. I know many people or many physicians, they like fluoroquinolones to be started empirically. Especially, I found anybody urologist here, urology, they love Cipro, okay, but or fluoroquinolones, let us say. But please note that in UAE, the resistance of is high, is 40%. So Cipro or fluoroquinolones in general are not a good choice to be started empirically for patients with UTI. Now, we based our guidelines on UAE antibiogram. At that time, we looked into the 2019 antibiogram. We will review the guideline again coming January or February, and we will see the new data that was presented by Dr. Jens. So how we've done it, we sat together and we took the two most common organisms that cause UTI, which are the E. coli and the Klebsiella. And then we looked into the different sensitivities of these organisms. And I know this is a busy slide, but we looked into the overall sensitivity, the sensitivity in outpatient, inpatient, and ICU. So we excluded ICU since we are not dealing with urosepsis. So we concentrated on outpatient and in pyelonephritis also for inpatients. So, and then we try to look into the antibiotics with highest sensitivity to E. coli and Klebsiella. And also with the help of Dictorians, we've done combined antibiogram. For example, looking into if we give amoxiclav with gentamicin, is the sensitivity going to improve, and so on. For example, ceftriaxone plus genta or amikacin. So let us just see an example here in E. coli. If you see amoxiclav, sensitivity of amoxiclav is 74%. As a rule, when you want to use an antibiotic as an empiric, you should have a sensitivity of at least 80%. However, it was very difficult to find an oral antibiotic with a sensitivity of 80%. So this shows that really we are in trouble. So we excluded the fluoroquinolones, we excluded all the fluoroquinolones, what else? Cefuroxime. So all these are excluded from an empiric oral antibiotics because the sensitivity is low and the resistance is high. And then we try to do combine. So you see, if we combine amoxiclav with gentamicin, the sensitivity increases from 74% to 93%. And if we combine it with amikacin, the sensitivity increases to 99%. So we worked on these, let us say, antibiotics, trying to do different combination and to reach to the best combination or the best single agent that can be given orally. Okay, so I tried to do some comparison between 2019 antibiogram and 2020 that was presented by Dictorians. We don't have data for fosfamycin. Nitrofurantoin is almost the same. Amoxiclav is also the same. However, you see the resistance of E. coli has increased from 50% to, sorry, this is the sensitivity, okay? So the sensitivity has increased from 50% to 62%. So we are slightly doing better with Cipro. Klebsiella overall is not really very good. Nitrofurantoin sensitivity in 2019 was 34%. In 2020 is 26%. So as you see, there are barely oral antibiotics that can or have a good sensitivity to Klebsiella. This is our antibiogram in Fujairah Hospital. And in general, we are very similar to the national UTI. So even if you have a national guideline, but if you have your own antibiogram, you have to adapt it to your own hospital antibiogram. You maybe have a better sensitivity, for example, to nitrofurantoin or better sensitivity to fluoroquinolones. So you have to see and adapt the guidelines to your own antibiogram. So I try to compare between Fujairah Hospital sensitivity in 2021 and the national report in 2020. And for example, for amoxiclav, unfortunately, our sensitivity is 58%. Cipro is even much lower, is 45%. So we cannot use Cipro, for example, as an empiric. So You see, while nitrofurantoin, this is an E. coli, the sensitivity is 94%. So nitrofurantoin would be a good choice for cystitis. We talked about complicated and uncomplicated. Uncomplicated cystitis means it is it only happens in or UTI in a non-pregnant premenopausal woman. So any non-pregnant premenopausal is uncomplicated. Other than this, all is complicated. Male, all the other risk factors. Pyelonephritis also, again, the same, non-pregnant premenopausal. Okay, without any abnormalities in the urinary tract infection, without any risk factors. Okay, so the risk for complicated UTI is as shown. There are many risk factors, including postmenopausal, including pregnancy. Male gender is always considered as complicated. So it's very important that you classify the UTI into complicated and uncomplicated because, as you see, the treatment is different. Now, a lot of patients comes, you do urine analysis or urine culture, and you find bacteriuria. So bacteria in the urine, but without any symptoms, is called asymptomatic bacteriuria. So in which of the following screening urine culture is not indicated? So we usually do not ask for a screening. Patient who is asymptomatic, we shouldn't send urine culture, except which one is not indicated in this? Any? No? Okay, great. 3. So in pregnant, even if they are asymptomatic, you should order the screening because if they have asymptomatic bacteriuria, they are at risk of premature rupture of membrane and premature delivery. Prior to prostate biopsy, because it can lead to serious UTI, and also post-renal transplant, especially in the first few months. So we talked about asymptomatic bacteriuria, and there is a criteria. In women, you have to take 2 consecutive samples. However, in male, 1 single sample with more than 100,000 colony-forming unit is considered as asymptomatic bacteriuria. Okay. So risk factors, again, either like obstructive uropathy or urinary catheter or frequent instrumentation of UTI, like frequent surgeries or catheterization removal in and out. Many patients, they have in and out catheter, so they are at risk of bacteriuria. Now, how we manage if the patient does not have symptoms, no treatment, except in these 3 conditions: in pregnant women and in prior to any urological surgery. So if the patient is going for any urological surgery, including cystoscopy, prostate biopsy, they have to be screened. And if they have bacteriuria, they should be treated. And as we said, in renal transplant, especially in the first few months. Now we go to cystitis. Again, you have to divide cystitis into complicated and uncomplicated. So this is the treatment of complicated and uncomplicated, first choice and alternative. Both are the same, as you see, nitrofurantoin or fosfomycin. If you have nitrofurantoin slow release or the regular, the difference is the duration. So for uncomplicated cystitis, the duration is for 5 days, while in complicated cystitis, the duration is for 5 to 7 days. Now we go to pyelonephritis. In pyelonephritis, again, complicated and uncomplicated. And in uncomplicated pyelonephritis, you have either the choice between amoxiclav plus aminoglycosides or ceftriaxone plus aminoglycosides. Aminoglycosides should be used only for 3 doses, and until the culture is back. And then if the organism is sensitive, you can de-escalate. Now, if the patient has penicillin allergy and you cannot use penicillins or cephalosporins as monotherapy with aminoglycosides is indicated. Here, the treatment can extend up to 10 days. Now, if you suspect the patient having ESBL, extended spectrum beta-lactamase, from the history, previous antibiotics, the patient was colonized before, we here suggest ertapenem for 7 to 10 days until the culture comes. So if your patient is having penicillin allergy, this is what we suggest for them if they have pyelonephritis, both complicated and uncomplicated. And all of these treatment will be for 7 to 10 days. Now, during pregnancy, is also UTI during pregnancy can be challenging because not all antibiotics is suitable that we mentioned in non-pregnant is suitable. Okay, so and remember that this is symptomatic UTI. It's different from asymptomatic. Asymptomatic also you have to treat in a pregnancy. Sorry. Okay, I'm sorry. Again, nitrofurantoin can be used during pregnancy. Fosfomycin. Alternative is amoxiclav. The duration is 5 to 7 days in cystitis. And then, of course, there are no aminoglycosides during pregnancy. You can use peptazo, or if you suspect ESBL, you go for ertapenem. Now, additional recommendation per agent, fosfomycin is not recommended for if you suspect pyelonephritis or perinephric abscess. It is only used for cystitis. What is good about fosfomycin that it covers multi-drug resistance infection, and if you don't have any other alternative. It is a class B in pregnancy, but also the data is limited, so it usually can be used during pregnancy. Again, nitrofurantoin is the same. You should not use it if you are suspecting pyelonephritis, or if the creatinine clearance is less than 60, or the patient with G6PD deficiency. Again, it is category B in pregnancy. Okay. And its concentration at term during labor and delivery. So, contraindicated in these patients near term and during labor and delivery. Aminoglycosides, the dose calculation, if the patient is non-obese or underweight, you use the total body weight. However, in obese patient, you use the ideal or adjusted body weight. This is very important. We suggest to use the single daily dose regime. For example, gentamicin 5 milligram per kg as a single dose. If the patient has renal function is normal, you don't need to check the level because you are only going to give the 3 doses until the culture is back. De-escalation is one of the important principles of antimicrobial stewardship. The meaning of de-escalation is that when you get the culture back and you find a sensitive organism, for example, if you start ertapenem thinking that this patient is having ESBL, and then the culture came down that it is E. coli sensitive to everything, including ceftriaxone, So what you have to do is de-escalate, stop the ertapenem, and change it to ceftriaxone, provided that the patient is also clinically improving. Like his fever is coming down, he's hemodynamically stable, not in the ICU, and you can also de-escalate from IV into oral. For example, if the patient is on third generation IV antibiotic, you can de-escalate to third generation oral antibiotics. So we have do and do not in UTI. So do not order screening cultures in asymptomatic patient except in the 3 conditions that we mentioned. Do not treat asymptomatic bacteria, even if the patient, bacteriuria, sorry, even if the patient is having MDR. For example, patient without symptoms, not pregnant, not for urological surgery, and you find ESBL Klebsiella or MDR Klebsiella, and this should not be treated. Okay, and for UAE, do not use trimethoprim, sulfamethoxazole, or fluoroquinolone as empiric because the resistance rates is high in UAE. And then what's happening? Yeah, now we have the do. Send the screening cultures in pregnant and before urological surgeries and in renal transplant. Treat only in these conditions, asymptomatic bacteriuria. We suggest using combination antibiotics if the patient is having pyelonephritis, because whatever antibiotics we have, the sensitivity really improves when you add aminoglycosides. And then do not forget the principle of de-escalation. And this is the last slide. These are the references. And thank you very much.
Thank you very much, Dr. Nihat. I think there'll be plenty of questions at the end of the session. We move now to our Dr. Mu'ina Zain, the consultant ID at American Hospital Dubai, a member of the National Antimicrobial Stewardship Committee. She will be talking to us about the National UAE guideline for intra-abdominal infections.
Assalamu alaikum, everyone. Good evening. So my next 25-30 minutes are about the second guideline that has been put out by ASB committee, which is a national guideline on the empiric treatment of intra-abdominal infections. I don't have any conflict of interest. And the talk is essentially divided into a few slides about what intra-abdominal infections are and what is their impact on our healthcare infrastructure, a little bit about guidelines, what they are, what limitations they have, and what harm sometimes they can do, and then the guideline itself. So intra-abdominal infections are surgical emergencies, and they contribute greatly towards the mortality in a hospital that comes from non-trauma cases. And they are present in all sorts of countries, in all socioeconomic status, in all ages and genders, and they have a toll on life, productivity, and resources of the healthcare structure. In the recent study, the mortality was counted around 9%, and this rises sharply if you reduce the source control and antibiotics are delayed for any length of time. Although the mortality is still high, over the last 15 years, several advancements in medicine have happened. For example, sepsis is now identified much earlier. ICU care has increased significantly, improved significantly with devices and with many other medications. So what used to happen previously, where patients would come in with refractory shock and multi-organ failure and succumb to it, now are living longer so that they have a longer ICU course and turn into sort of a chronic illness where you have multi-organ dysfunction, but it's still manageable. And this is quite heavy on resources of the hospital. And eventually, of course, there's generally quite a poor outcome. Whenever you have an infection in a hollow viscus, we all know that the organisms come from inside the lumen. So these are endogenous organisms which attack the organ because of a break in the mucosal barrier. Most of the time, they are gram-negatives and they're anaerobes. Although some etiology may change, upper GI doesn't have anaerobes. It's interesting to know that almost 400 different organisms are present in the colon, but for some reason, and mostly because of culture issues, we generally only routinely culture out between 4 to 6 microorganisms. Now, intra-abdominal infections are not medical conditions, they are surgical conditions, they are surgical emergencies. So the primary cornerstone of treatment of these infections remains source control. Source control is defined as all physical measures that are done to control the source of infection and to bring the organ back to its functional capacity. This may be in the form of resection of a gangrenous appendix. It may be drainage of an abscess. It may be lavage, peritoneal lavage with peritonitis, or it may be resection or stitching up of a perforation. Whatever it is done, all of that is considered source control for these type of infections. Now, like other areas in medicine, this type of infection also is well known to have a much poorer outcome in hospitals that either do not have guidelines or do not adhere to the guidelines or simply don't have resources to follow them. So the most recent guideline that takes care of management of these type of infections was published in 2021 by a large conglomerate of international agencies, including the World Society of Emergency Surgery, the Global Alliance of Infections in Surgery, and many others. This is a multi-center guideline, and in fact, it includes Dr. Ashraf from UAE as well. Now, what is it? What is a clinical practice guideline? So, according to the Institute of Medicine in Washington, D.C., these are statements that make recommendations about different modes of treatment for different infections that are based on a systematic review of available data so that they decide what works and what does not work. Under normal circumstances, I mean, all of us here make complex decisions. And since we do them so often, we don't realize all the different components that go into making any complex decision. So if you look at the larger circle, that may be the organization you're working in or the country that you're working in. But then there are several other components. So for example, here, okay, this doesn't work. You may be looking at your patient demographics, the severity of the illness, the insurance that the patient has. You also need to know what are the resources available to you, whether you have this drug in the formulary or this piece of equipment to do the surgery. But you also need always to know what the data says, right? And there's no point in wasting time and resources in something that other people have studied that you don't want to do. And this is essentially what a clinical practice guideline does. So the benefits of a guideline are, when they are properly admitted, they promote evidence-based medicine. They reduce the variation that different physicians, different hospitals in different countries will have in treating the same condition, and therefore provide standard of care. In a healthcare facility, if you are able to implement, and there's compliance to a practical guideline, it results in improved patient care, decreased length of stay, reduced visits back to the emergency room or to the clinics, better frequency of monitoring, and all of this is done at a much less cost than before. But there are certain potential limitations of guidelines as well. First and foremost, they're all based on data. And data can be misinterpreted and sometimes manipulated. But more importantly, and more common than that, there are very few areas of medicine that actually have robust clinical data, the kind that we like. So even in guidelines that we all follow, if you look at the gradations where it says strong recommendation, very often this will be followed by low quality of evidence or even expert advice. So simply the data, the randomized control trials that you would like simply does not exist. So many places that we go on whatever is available. The other thing is that sometimes recommendations are, recommendations are made by people. So they bring their own issues and opinions and whatever attitudes they have to the guideline. Then sometimes guidelines are not made with patient care at the focus. They can be working towards reduced cost, for example. And especially this comes when the guidelines are being made by payers or, for example, governments that do Medicare, Medicaid, etc. So they're always looking at cost. And lastly, a guideline needs to be looked at just as a guideline. If we are too rigid about it, we may miss patients who may need a little bit more customized or individual care. But despite all of those potential limitations, we like guidelines. We want them because overall they are good for standard of care. So the intra-abdominal infection guideline in UAE was made or formulated or put together under the umbrella of the ASP committee, and you've heard about it. And the reasons for doing this, of course, is what we just mentioned, to promote stewardship, to promote homogeneity in treatment of these cases, to prevent the emergence of resistance and dissemination of resistance, improve the quality of care, and then potentially maybe these can be used also as performance indicators. Now, you've just heard the UTI guidelines. But compared to the UTI guidelines, we had some challenges. The task force had some challenges in putting together these guidelines. Number one was that intra-abdominal infections is a large umbrella under which you have a very simple case, so a healthy 18-year-old who's coming with acute appendicitis, but you also have a stage 4 colon cancer coming with intestinal obstruction. So the variety of different patient populations was quite diverse. And, so it was challenging to try and cover all of these different types of scenarios. The second challenge that we thought had is we wanted to make the guidelines simple enough to be followed by all physicians in all types of hospitals, but it also needed to be comprehensive enough that major or common situations don't get left out. The third point was that you've just seen Dr. Nihat's presentation and how accurately we were able to extrapolate the sensitivities in our UAE surveillance data and then put them down into the guideline. So that luxury was not available to us because there are extremely few intra-abdominal specimens in our UAE guidelines. And this is not a deficiency of the system. It's just that, generally speaking, cultures are not recommended except for severe patients. This may change in the future. In particular, I think it will be very good in very sick patients. We do take cultures so that we know what we are dealing with, and guidelines might need to be changed. It's also true that throughout UAE, we have a very great variation in hospitals regarding their resources and in their stewardship overview. So these were some of the challenges we had in putting the guidelines together. So now let's talk a little bit about the guidelines themselves. The purpose obviously was to provide healthcare physicians with a document that would be evidence-based and readily available to help people when they are facing these patients. We do recognize that the guideline is current with the current literature, which changes. So obviously these guidelines would have to be revised every 3 years so that we can remain relevant to the patient population. We've just heard about the ASP committee. It is a committee that has varied members, which brings together quite a rich experience to the committee. There was a task force made by the committee which put together the guidelines, and then the guidelines were disseminated for approval, not just to the committee, but also to stakeholders outside into several other hospitals. So we start with the definitions. We first defined a simple or uncomplicated intra-abdominal infection as an infection that is limited to a hollow viscus. Then it becomes complicated when it spreads out to the contiguous areas, which may be peritoneum or mesentery or any other organ. We define the hospital-acquired infection as anything that starts after 48 hours of hospitalization, and then source control we've already talked about. What we did not cover is clinical manifestations and diagnosis of the intra-abdominal infections. We also did not cover some relatively rarer conditions that cause intra-abdominal infections, for example, small bowel perforation or pelvic inflammatory disease. Now, because there was such a wide variety of patients that the guideline is supposed to cover, we put in a section in the beginning of the guideline that talks about principles of treatment in these type of infections. And we start with saying that the cornerstone of intra-abdominal infections is always source control. So the earlier you diagnose the condition, the quicker the source control can be done. Of course, we need the appropriate antibiotics, and we need to stabilize the patient. The stabilization of the patient, of course, is primary, because without that, the source control cannot happen. Right, so we talk about the empiric antibiotic treatment should start as soon as possible. And it needs to be targeted towards gram-negatives and anaerobes, as we already talked about. Given that we have almost a 30% ESBL rate in the community, we wanted also to emphasize that different hospitals should be looking at their own data and to assess the patient for risks and risk stratify them on whether they are at risk for having MDR organisms. We have sort of assumed that community-acquired infections will be low risk. That may not always happen, but generally speaking, healthcare-acquired or other MDR would be patients who are sicker or patients who have been to a hospital recently, and there's a table that shows about all those risk factors. And then we also said the coverage of anaerobes may not be necessary in every single patient. Then general principles of antibiotic use, we would like antibiotics to be de-escalated as soon as possible. And we also don't want the preconceived idea of a 7-day treatment or 10-day treatment. Rather, we would like to encourage a daily evaluation of the need of ongoing antibiotics, because many of the newer guidelines are talking about shorter durations when the source control is adequate. Now, nowadays, as part of stewardship, the drugs have to be delivered appropriately, right? So this would mean that you choose a drug which penetrates properly and it gets wherever you want it to go into good enough concentration. So this might mean that you may need a loading dose, you need a continuous infusion, it may mean you might reduce the dose because of renal failure. So the pharmacokinetics and pharmacodynamics obviously are very important for all antibiotic use. So the conditions that we've covered essentially are these. And then we've divided them, just like the UTI, we divided them into uncomplicated and complicated, because that changes the regimen. So essentially, this is the format we've used, which is the same as our UTI guidelines. The first column essentially tells you the drug of choice. The second will be the drugs that are available or should be used in penicillin allergic patient. And the third column, we just kind of used to put small comments or pertinent facts that we want the healthcare physicians to think about. So most of the intra-abdominal infections, which are low risk, we used second and third generation cephalosporins along with metronidazole. I think pretty much everybody uses that. For our penicillin allergic patients, we used Cipro and Flagyl. But you may notice that at least for acute appendicitis, if it is a patient that has non-perforated appendicitis and the source control is adequate and timely, it is possible that you may discontinue antibiotics after the appendectomy. So we don't need 5 days, 7 days of treatment after the appendix is removed because the source control is adequate. If it is a perforated appendix, then we recommend at least a 4-day course. And, obviously clinical evaluation will be a part of this, but it is possible if the patient is doing really well to stop at 4 days if even after a perforated appendectomy. If there's no appendectomy, we do end up increasing the total duration of antibiotics. And this is one very good reason why source control needs to be done properly. Otherwise, we end up using a lot of antibiotics. And this would be either a community-acquired appendicitis that is severe with sepsis, with shock, or it is somebody who is high risk for a multi-drug resistant organism. This may be because he's been in and out of the hospital, has been recently taking antibiotics, or has procedures done, for example. So in this scenario, we are recommending piperacillin-tazobactam to start off with. We can use that in 2 doses, either 4.5 Q8 or 3.375 Q6. Or if the patient is in shock, we recommend meropenem with or without vancomycin for possible enterococcal coverage. Now, because this is a more serious condition and you may have less time, we do not want Cipro and Flagyl to be used when there's a penicillin allergy. So if it is a low risk, meaning a history of rash or a vague history, you go ahead and do the 4th generation cephalosporin along with the Flagyl. And if it is a high risk, like a type 1 hypersensitivity, or, patient tells you my throat closed up or something, then we are recommending Astronam with Flagyl. I realize that Astronam is not available in all hospitals, in fact, in many hospitals, including ours for now. So there may be other options like tigecycline or aminoglycosides that we can do. But this becomes a more complicated scenario. Okay, and then we have given oral step-down treatment as well, which is mostly augmentin, or again, an oral cephalosporin with Flagyl. And ciproflagyl can, ciprometronidazole can just switch to PO as well. So in the previous slide, maybe you can see in the 3rd column, there's a comment that says see comment 6.7. So I just wanted to show. So for example, 6.7 is a comment about the low susceptibility of E. coli to Cipro, which we just saw in our last slide. So when you have a patient who's really sick, we will have to use an alternative drug. Now, for acute cholecystitis and acute cholangitis, again, if it is community acquired, same first-line drugs, the same penicillin-allergic patients will get the same Cipro and metronidazole. But in the comments, we put that in uncomplicated cholecystitis, pre-op doses might be enough if your source control is adequate. So post-operative doses may actually not be needed. And then same 2 drugs, piperacillin-tazobactam plus minus vanco and meropenem plus minus vanco. Many of our ESBL organisms are susceptible to piperacillin-tazobactam, but in a severe patient who has shock or you are suspecting bacteremia, piperacillin-tazobactam should not be used and meropenem should always be preferred. So in this patient in the comments, for example, we've also put that most patients with cholangitis should get an MDR type coverage because cholangitis almost never community acquired. There's always some underlying organism. So I'm going to show you a comment because it says C comment 4.3. And then lower down, it says extended duration inadequate source control. And there's a comment that also, which I will show you just to. So this table essentially tells you what are the risk factors. And the lower half tells you also that there are scenarios where you may have a carbapenem-resistant organism or a pan-drug-resistant Acinetobacter. So instead of giving you drugs, we have opted to just say, please consult either infectious disease or anybody else who has experience with these. Because the regimens change with the genotype, and we don't have genotype, but with the type of enzymes that are available. So it's better to have somebody else who knows, has experience with these. And the next comment that we had was, if you have a patient who's got the source control and the inflammation doesn't seem to be going away, then rather than switching the antibiotics, more diagnostic workup needs to be done. The patient may have either a collection or may have a totally different infection, for example, a line-related infection. For acute diverticulitis, we wanted it not to be treated with antibiotics if there's no fever or leukocytosis. If you do want to treat this patient, the regimen will remain the same. I wanted to, yes, the last line that you may see here is that when diverticulitis becomes very complicated, it really ends up into peritonitis. In fact, many other conditions end up into peritonitis. So we have referred this reader to that section. Now, esophageal perforation is a true surgical emergency. It progresses very rapidly, turns into mediastinitis. So we have been very aggressive in its empiric treatment. So we do want piptazo because it covers the anaerobes, the peptostreptococci, as well as the gram-negatives and the pseudomonas even. And this is probably one of the few conditions where we want antifungals to be started right on the onset. We do recommend an ID consult highly in these cases. The duration cannot be determined because it depends on how the patient does and have to be assessed clinically. We do think that the patients who are so sick that they are in shock or they may have candidemia, we do not recommend fluconazole, but would prefer that echinocandins be started in this scenario. Now let's move to peritonitis. Everybody knows ceftriaxone for SBP, stepping down to either Augmentin or any of the cephalosporins. But we also have a section about prophylaxis of primary peritonitis. Now, these are cases who have not yet had peritonitis, but you're trying to prevent it. These are generally patients who have cirrhosis. There are three populations that you want to start ceftriaxone on to prevent peritonitis. Number one would be patients who've had previous several episodes, so you want to prophylax them. Number two are patients who have cirrhosis and have protein levels in the acidic fluid less than 15 grams per liter. And then the other are cirrhotic patients who are actually admitted for any other reason, but a 7-day course of ceftriaxone is recommended in these patients as well. Did it change? Okay. Secondary peritonitis, which is often the end stage of many other complicated infections. If it is community acquired without any other risk factors, we will still continue with the cephalosporins and the metronidazole. And we do believe that the treatment duration will depend upon source control. And if it is community acquired, again, the same 2 drugs. Here I wanted to mention also that for sick patients, loading doses for piperacillin tazobactam also are a good idea. So you can start with 4.5 and then you can do either 3.375 Q6 or 4.5 Q8. We do not recommend Candida coverage empirically, and there is a so in the last column, I wanted to mention 2 things. One is that there is a small comment about which type of patients you want to do enterococcal coverage in when you are doing empiric therapy. Not everybody will need vancomycin, not everybody will have enterococcus as a big player, but there is a subset of patients, as evidenced here, that might need empiric therapy with it. The second comment is if bacteremic, see comment number so-and-so. And this is again durations of bacteremia that can be done safely. And you can see that they're quite shorter than we are used to. We're used to doing 10-day courses for bacteremia, so these are quite different. But there are exceptions to this. So patients who are high risk, like immunosuppressed patients, you don't want to do the short course. Tertiary peritonitis is really more of the same. The only thing I wanted to mention here was that many of these patients have already had surgeries and they may have drains. So do not culture the drain fluid because it's almost always a colonizer and distracts. Most colonizing drugs are MDR. They are much more resistant than pathogens that are actually causing the problem. So that should not be guiding you. And MRSA is almost never present, so we don't need to cover that. This is a comment about which sort of patients need enterococcal coverage. For acute pancreatitis, it's always a little bit difficult to withhold antibiotics because these patients are so sick. But most studies now do recommend that antibiotics are not needed as long as we don't think there's necrosis or an abscess. And if you feel that the patient is worsening clinically, then you will need a CT scan and we need to rule out an infected pseudocyst or a necrosis. In that case, we will have to do more aggressive therapy, but also do CT scans to see whether diagnostic as well as therapeutic drainage can be done. Okay, so now the recommendations, the various conditions for recommendations are over. I just wanted to mention to you a couple of tables that are at the end of the guideline. Now, these are surgical emergencies, right? So it is very important to do risk assessment for mortality and also for management. So these are SOFA scores, which are organ failure assessments. There are various tables that most hospitals use. This one is a little bit complicated because it involves respiratory settings, etc. But there's a very nice quick SOFA score that can be done at bedside, because it's just the vital signs that are available to you at the fingertips. And this gives a good assessment of the patient, whether it's becoming septic or is going into septic shock. And then this is a table that tells us what are the risk factors in which a patient will have higher risk of getting MDR organisms, so we can adjust the regimen accordingly. And this is a very nice table, which actually divides your immunosuppressed patient into three categories, where minimally immunosuppressive or moderately or severely. So this would also help a little bit in deciding what you want to do. So this is my last slide. So I think what is different in this guideline is that shortened regimens are being encouraged. And this is going to become a bigger deal in future, I think. And recommendations for doing intra-abdominal cultures, I think, should be a guideline, because it helps to modify our guidelines and also test out our regimens. Less anaerobic coverage, because we know that the more you kill the anaerobes, the easier it is to do selective pressure. And risk stratification of every patient who needs antibiotics, I think, is the buzzword. And that's the only way forward, so that we can conserve antibiotics while not putting the patient at risk. And thank you.
Thank you very much, Dr. Marina. I think we'll ask the panel for just to have the seats in the front, and the floor is open for questions. You can put up your hand so we can give you the mic. Okay, if I may ask one of the questions from the online. Perhaps Dr. Jens, how we can implement the susceptibility data into practice? I think you mentioned it, but perhaps we can just summarize it again.
So the susceptibility data that is presented usually in these reports as a form of a cumulative antibiogram. So this is what we are using on the national level to inform the development of standard treatment guidelines, like Dr. Nehat has nicely shown for the urinary tract guideline. But also this can happen on the local level, on the hospital level. So hospitals also can develop their own guidelines if they feel they need to, and use like their own resistance patterns, susceptibility pattern, which can be quite different from the national average. So I think also hospitals need to be utilizing their own data to the max and requesting their own labs and their own microbiologists to provide them with the same data which is relevant for their hospital. And that has to influence their own treatment guideline development if they want to develop their own guidelines.
Thank you very much. Here. Okay, another question. Perhaps Nihat, do we monitor implementation of these guidelines in the clinics and hospitals?
Ideally, we should, but as you know, that we have different hospitals and different clinics, many clinics. So really to gather this data, and we need more, let's say, human resources. And maybe, as Dr. Jens said, the central office that, these clinics and hospitals submit their data. But we encourage hospitals to have at least one KPI. For example, not using fluoroquinolones as a first-line therapy for UTI and so on. So, but at the national level, we are trying to figure out let us say, an easy way or an acceptable way to monitor, the compliance.
Yeah, I agree with you. I think it's always, maybe because you work in the government, it's very easy to get data from the government. However, when we approach the private, the response is really not as great. We just sent out, the UTI was published last year, and just towards the end of the year, we just sent a quick survey to all facilities in UAE, and the majority of response were with the government hospital is that yes, they are aware of the national UTI and they are referring to it into their guidelines. However, in less than 50% of the private actually had responded and said, yes, we know about it. So I think we should, hopefully something like this will publicize our guidelines, and hopefully we'll also have some mandates perhaps sent out to the hospitals, which we need to work with centrally. The other questions is when are we expecting the perhaps the respiratory tract infection guideline to be released, or any other guidelines?
So we, in our last meeting, we've picked out the task forces for pneumonia, in fact, a respiratory guideline, as well as a skin and skin structure guideline. So hopefully those two will be the next. And I wanted to comment on the last question as well. So we, in American Hospital, we currently have a main campus and we have 7 satellite clinics. So about a year and a half ago, we started to check compliance for simple cystitis in our clinics. And honestly, we started with about a 30% compliance. But over years, because it's monthly, it's reported monthly to the ICC, over time, we've seen a very nice increase in compliance to the drugs of choice. We're just checking 2 things. We are checking whether the drugs are nitrofurantoin and phospho, and we just checked whether the duration is not more than 7 days. Because when I tried 3 days, it didn't work. But overall, with those 2 criteria, we've had a very good compliance of almost 85% now. So it can be done. It just needs some elbow grease.
And if they were not compliant, so what were you doing?
So we didn't penalize anybody. Where we identified physicians, and what we did, what I think works really well, is if you put the data of other physicians in your department not doing that, that's a very strong motivator. So if you have 5 primary care physicians and 4 are compliant and 1 is not, then all you need to do is make a chart of physician A, B, C, D, and physician C is like over the top. It makes them think, and you do it in a nice way. Nobody gets to know it's anonymous. So most of the time that works well.
Dr. Jens, somebody's asking about the frequency of updating the national surveillance report.
Yes, so the National Surveillance Report is an annual report, so we are publishing it on an annual basis. The last report, the first report that was published was coming out in 2021, which was having data until 2019. So now this year we published the 2022 report, which has data until 2020. And next year we will publish the 2023 report, which will have data until 2021. So it's an annual report and we're publishing it on an annual basis.
Dr. Heard about updating the guidelines on frequency?
Be 2 years. So the national UTI is due for review in this next February.
I have one question. I'm hesitating whether I should read it out or not. Is there any new update regarding specific use of antibiotics with COVID patients? I hope they're meaning secondary infection, not COVID. We do not use antibiotics to treat COVID. There are some antivirals, but they are for the very high-risk patient, as you're all aware. And it depends on which emirate in UAE you are or where in the GCC you are, that the availability of the drugs is different from one area to the other. As you all know, the newer strains, or not, the current strains, shall we say, are quite mild, so it's only we target only the immunocompromised really. And by immunocompromised, we mean not diabetic patients anymore, but perhaps the elderly, the people on immune suppression, perhaps transplant patients, and maybe babies as well. As for the antibiotic, it is not recommended to use for COVID unless you have a proven secondary infection, and there is a criteria for it. As we all know, the co-infection is less than 10%. Less than that. Anybody, any comment? Any questions from the floor? Any extra questions? Yeah? Okay. Some more online questions. I think some people, maybe gynecologists, are also with us, and they want some guidelines for cesarean high risk. I'm not sure I understand the question. Maybe you, perhaps treating surgical site infection.
Maybe treating surgical?
Yeah, maybe treating surgical, because pre-op, there is a one dose of medication. It depends on your population, but tifaziline is one, plus sometimes some others may add. However, there is no any other treatment unless you have a surgical site infection. Then we go to skin and soft tissue infection.
Again, in general, you have to risk stratify your patients. Is your patient at a higher risk of resistant organism like MRSA? So I know some hospitals are doing MRSA screening for ladies before cesarean section. If the patient is colonized, for example, with MRSA, or patient has taken antibiotics in the previous 3 months, then we start to think that this patient might be infected with MRSA, also diabetics. So there are certain risk factors. So we go for example, anti-MRSA. In general, it is gram-positive organisms that is causing the surgical site infection regarding cesarean. So this will be probably will go towards the skin and soft tissue infection.
You can always look at your antibiotic to see really what is the prevalent organism in your C-sections. Some might have gram-negative. Okay, there's a question. What do you think about the role of clinical audit in improving prescribing antibiotic in healthcare? Depends on the resources, I suppose.
It would be wonderful, of course. But as Dr. Najib said, it needs resources. I don't know what Nihat does. We basically just monitor our carbapenem use. So we do a monthly consumption data. We break it down to indicated or not indicated, and we do per 1,000 patient days of therapy per 1,000 patient days in the hospital. But for the other drugs like targetious cephalosporins or fluoroquinolones, for example, we don't have the resources as yet. It would be good to do.
Yeah, we monitor 7 antibiotics, carbapenems, echinocandins, others, vancomycin, for example. And
They're restricted.
well, we because we don't have an ID physician, it's not a true restriction. It's like a prospective audit where the physician will write a form, and this form will go to the pharmacy. The clinical pharmacist will review the antibiotic within 72 hours, review the appropriateness of this antibiotic. And then the data are presented every month in the ASB committee, who are which departments have the highest compliance or the lowest compliance, and so on. So for pre-authorization is really a bit difficult. And, it's difficult because again we don't have the resources, and then pre-authorization needs somebody who is really either specialized in infectious disease or have a huge experience.
Plus, also they have to be consistently available.
Yes.
Patient cannot wait.
Yeah. Like, for example, in the weekend, if you don't have somebody working in the weekend and you have a patient with like serious infection, you cannot wait for two days and Monday, for example, until somebody's available. So pre-authorization means that you write the antibiotic and then the concerned person, whether clinical pharmacist or ID physician, will discuss with you whether this is needed or not. The pharmacy won't dispense the antibiotic unless it is approved by the, let us say, the ASP team. So this, or maybe the first dose is dispensed and later on. But this is really difficult because it needs a lot of resources. It needs somebody working the weekend, and it's.
Thank you. Another question is, Dr. Jens, would you like to explain the importance of surveillance of UTI in the community?
Sentinel surveillance.
That's what they asked. I'm not sure what that means.
So as an epidemiologist, I mean, when we talk about sentinel surveillance, we usually mean a targeted surveillance. Like there's a certain hotspot or an area of interest, we do like a dedicated targeted surveillance on that kind of area. So if the question is about the importance of sentinel surveillance for UTI in the community, it could make sense, yeah, to have a look at like a focused, targeted look at what's going on in terms of urinary tract infections in the community, in the like outpatient community. Because usually when we do the national surveillance, it's like an average across like all the organisms, all the patient groups. But yeah, as we can, with the data we have, we can drill down and filter. Emirate by emirate, we can like differentiate between inpatient, outpatient, ICU, like Dr. Nehat has shown. So that's what we actually have done, right? When we developed this guideline, we were looking not at the ICU data, we were looking at outpatient data and the inpatient non-ICU data. So it's kind of a sentinel surveillance within the overall surveillance, what we are doing. So it's possible to filter and drill down the data and look at particular areas of interest.
Thank you very much. I think these are all the queries. Thank you very much, Dr. Jens, Dr. Nehat, Dr. Maina. It's been very interesting to listen to you all. And thank you for our physical audience and online. Thank you very much, and hope if you have any question, you can always direct it to Mr. Zaki or Hamdi, and we will be happy to get back to you. Thank you very much for now.